Thank you very much. I appreciate that. And again, welcome everybody. I'm excited about talking to you about advances in microwave ablation and hopefully a motivation or potentially even plea to move towards that aspect. Significant advances have been achieved in the management of hepatic malignancies, to which minimally invasive hepatic ablations is one of those. From this talk, I'm hopeful that I'm going to demonstrate to you hepatic microwave ablation in the surgical setting, review some of the evidence-based medicine, and then kind of give you a little bit of my opinion-based practice, where I think it plays a role, what should someone who wants to start a hepatic ablation program should think about, and then what are some of the minimum standards that are required to initiate that type of high quality type of microwave ablation type of program, etiology, as well as collaboration through a multidisciplinary type of approach. And then also understanding that in initiating that, there are well-established standards for the use of this technology in multiple malignancies, demonstrating its benefits and equivalency to hepatic resections based on certain size and locations. Now, it's an incredibly exciting time to be focused in hepatobiliary malignancies. As you can see here, the current therapies for hepatic malignancies continue to evolve. Some which are maybe falling off, some of those, some that are clearly rising. Surgical resection, both open, laparoscopic, and robotic, still play a critical role and obviously are one of the most efficient ways and most effective ways for removing visible malignancies. Local regional therapies that can be utilized potentially for downsizing lesions, as well as the ability to bridge patients to either transplant or more extensive resections have also been utilized, both with transarterial chemoembolization, drug-eluting beads, and radioembolization. Clearly, immunotherapies and the use of first, second, and even some third-line therapies have clearly demonstrated the types of benefits that can be achieved in patients. What I'd like to do is to go over what is the true volume. Some of you who may not have an ablation program, who are attempting to utilize one, or more importantly, want to grow one, I want to show you some of the informational data within the United States in regards to over a year time from 2017 to 2018 in regards to the numbers that have been utilized for hepatic resections and ablations. 73%, though, still in 2020, are obviously performed through an open resection. Our country has been slightly lagging behind that utilization of minimally invasive approach, either laparoscopically or robotically. However, you can see that majority of ablations are performed, a large percentage of ablations are performed in a small number of facilities. Interventional radiologists are still performing a vast majority of ablations, 55%, but surgical use of ablation is performed in obviously various techniques of open, laparoscopic, or a combination of ablation and resection in certain malignancies. If we look at the true numbers over this 1 year time from March 17 to 2018, you can see that the number of open liver ablations are a little more than 2,200, and that the use of laparoscopic liver ablations is only a half of that number. But most importantly, you can see the significant number of patients who are undergoing percutaneous liver ablations. So the ablation need and the optimization or the use of ablation is clearly there within the United States and is clearly an area that further collaboration, but more importantly, expansion of patients who can be offered this treatment is of critical utmost importance. Again, breaking down where a majority of ablations are being performed is in obviously interventional radiology through a percutaneous approach. And surgery is still a smaller percentage, and that includes all types of techniques, as I've mentioned before. Now, what are the challenges to liver ablation? And ultimately, it really comes down to patient selection. If you remember nothing from this talk, I will tell you that patient selection is probably the single greatest factor that you as a treating physician can utilize in optimizing your quality of patients who undergo ablation, preferably a minimally invasive approach. Clearly, the disease status that you can see here, hepatocellular carcinomas, is vastly different than treating colorectal liver metastasis. The type of liver parenchyma can also obviously make a underlying ablation more difficult or easier. And the location of the lesion, subcapsular, high up on the dome of the liver. And so clearly taking all of these variables intact is of utmost importance to ensuring quality of your ablation. Now, the clearly most important around after patient selection is obviously biology of the disease. Do you understand that? It's not really can you resect or ablate the lesion. It's really about should you do it. What approach is best? So far in 2020, if we look at more of the major hepatic ablations that are being performed, our goal is to try and improve that to nearly 80%. In 80% of patients, those patients most likely can be treated in a laparoscopic approach, to which we have demonstrated near equivalent length of stay, meaning a less than 23 hours, but more importantly, a much higher degree of staging and optimization of those patients. The biology of the disease, and more importantly, the patient selection of that is, do you truly understand that type of biology? Meaning, if you do an ablation, are you going to allow that patient to be in remission or disease stabilization for greater than 6 months? I believe, personal opinion, that it's a failure of patient selection if you simply do a procedure and then 6 weeks or 12 weeks later, you see clear progression of disease. That was probably not an optimal utilization of that therapy at that present time, and where biology plays a role. As I said before, the hardest question is not can you, but should you do it? And telling the patient that ablation may not be the best option right now, maybe in the future, but getting a better control of their disease is of critical utmost importance to avoid unnecessary treatments. Patient workup and understanding that type of patient workup cannot be underestimated. Having high quality 3-phase liver protocols with thin cuts or dynamic MRI with the Avist within 3 weeks of the ablation is truly of utmost importance. I know many of you get pushback from insurance companies that they already had a CT scan, and it does sometimes take extra work to do that peer-to-peer. But I do find that having that short interval scan can ensure that a therapeutic ablation can truly be performed, and that you are not going to be doing a non-therapeutic laparotomy if you're doing it open, or a non-therapeutic general anesthesia if you do it laparoscopically. You start the procedure and you see that they have much more extensive disease. For hepatocellular carcinoma, understanding the radiologic signature is also important for patient selection. Our publication that came out in the Annals of Surgical Oncology in 2007 below demonstrates that there really are 3 different types of categories. Why those are important is about margin. Invaders clearly need a much larger degree of ablation margin than a patient who has more of a pushing type tumor, a well circumscribed tumor to where you can see the rim of that. A hanging type tumor is one you need to be more careful with the type of ablation, because the access point and how you ablate it could potentially put that at risk of rupture and seeding of the peritoneum. Radiomic signatures in hepatocellular carcinoma are growing, and I think being aware of that to allow you to predict the underlying biology, the microvascular invasion, is of utmost importance. Obviously, the tumor location, their underlying clinical tumor biomarkers, and their child's Pugh status. Hepatitis status for hepatocellular carcinomas are critical to make sure that you understand that. And then obviously the short-term goals, and then what are the long-term goals? Will your procedure, will this ablation potentially burn a bridge 6 months down the road or a year down the road? I always tell patients, regardless of the malignancy, hepatocellular carcinoma, metastatic colorectal, intrahepatic cholangio, metastatic neuroendocrine, make sure that you're truly playing the long game. It's not really what therapy they can get right there. It's making sure you manage that type of escalation of care to make sure that your therapy is not going to prevent them from getting a therapy later down the road. And then obviously their underlying frailty and what are the short-term and long-term goals of the patient. There is well-established ablation quality that all physicians, regardless of their access, percutaneous, robotic, laparoscopic, must be held to. And these have been well established and have been around since 2014. Must define ablation success. Ablation success for most of you seems fairly straightforward, but if you're not confirming that within 4 weeks of an ablation, then ultimately you're really not confirming ablation success. A local recurrence after an ablation cannot be called local recurrence unless you've had ablation success. It's impossible to call something a local recurrence at 3 months. If you didn't confirm that you had complete ablation at less than 4 weeks, that actually means you had an incomplete ablation, and it just took you 3 months later to define that. Non-local hepatic recurrence is also important, especially with dealing with multifocal cholangio or hepatocellular carcinoma. And then obviously the indications for ablation, understanding the morbidity and why this patient needs to be ablated versus why they potentially could not undergo surgical resection clearly needs to be evaluated and decided upon in a group type setting in that multidisciplinary fashion. These quality standards need to be long-term, evaluating your data at least every couple of years to make sure that your ablation success is reaching 96 to 98% on all patients ablated, that your ablation recurrence is less than 10%, preferably 5% is your ablation recurrence, and that your hepatic recurrence, progression, or extrahepatic is at least 6 months or greater. And that comes back to the biology. It doesn't take a huge amount of work, I think, to get these things, but it does take that type of insight to make sure these type of quality standards are upheld. Now, what about the technical considerations? What about the fun toys? Well, what can we use to do this? And ultimately, I think there are three things that you need to be aware of when deciding how you want to embark upon an ablation program. And some of it is internal, meaning what is your ultrasound skill set? Some of it is the ablation device that you may have or may want to get. And then the third part is the biology. And this is a fairly simplistic type of estimation, but I do find it's very important for both my fellow trainees as well as my new faculty who I'm training in regards to understanding how to embark on a type of ablation program. Starting with your ultrasound skill set on the left-hand side, truly being a critical evaluator of how good are you at ultrasound. Are you a basic user? And that means you want to improve? Well, then that's good. That's nothing wrong with that. But you can see that a basic user trying to use a highly cirrhotic hepatocellular carcinoma way up in segment 8 of the liver is going to be a very difficult, challenging, and maybe even frustrating case. Starting with your ultrasound ablation skill set, but also the underlying ablation complexity. Utilizing and evaluating normal parenchyma for small lesions, and you have an RFA machine, there's nothing wrong with that. I'm not going to sit here and tell you that one ablation modality is better than the other. I actually don't really compare them. They all fit a niche of what treatments are available and where they can succeed the best based on location, type of liver parenchyma, the size of the lesion, and even the location of the lesion. I think aware of that is critical so that you can start in an appropriate fashion on this curve and then hopefully then grow your experience over time so you can get to be an expert ultrasonographer and an expert ablator. These are truly things that can be trained and educated and gained through these types of webinar talks as well as other types of webinar talks. What about the technology? Microwave ablation's been around for a long period of time. I initially started to use it in 1996 with the 915 megahertz system, and have moved along and evaluated from that. I find that ultrasound is quite advantageous with treating larger lesions, 3 to 5 centimeters. They are less impacted by heat sink because a majority of my ablations are actually for hepatocellular carcinoma. It makes up probably 70% of my case mix is hepatocellular carcinoma, with the other 30% being metastatic colorectal, neuroendocrine, and cholangio. Hepatocellular carcinomas are obviously very vascular tumors where a heat sink effect can play a role. And that's why I like microwave ablation, because I can overcome that heat sink with the very rapid rise in temperature that you see here, which is one of the technical advantages over RFA if you're treating a larger HCC that may be closer to a heat sink type of vessel. I also like it because I use more of an active ablation, and that gives you a much more rapid ultrasonography image, which can allow you to assess your ablation volume a little bit more accurately than that slow, more of longer term radiofrequency ablation. Now, there are disadvantages. There is significant variability in microwave ablation devices, and I'll walk you through that in the next couple of slides. So buyer beware. Not all of the devices are the same. They are not all set up the same. The technical demands of their utilization are not the same. And understanding that for the type of patients that you either going to be referred or want to be referred is critical to make sure that you're choosing the right machine. There is a wealth of literature. This is a mere summary of it around hepatocellular carcinoma, with, again, local recurrence rates, some that are good and some that are not so good with certain types of lesions. Understanding that, and when starting a ablation program, maintaining that quality and following your quality, I think it's of utmost importance for patient care. Knowing the different frequencies of microwave. There are still a number of 915 microwave ablation systems out there. They work on a smaller power type of generator of only 55 maximum watts, whereas the 2450 megahertz generators can deliver up to 150 watts from the generator. Not all of that actually gets to the needle, and I'll walk you through that and why that's important. Again, for some of our audience who may not know how microwave ablation works, it's basically just causes rotation of water molecules. That rotation, similar to your microwave oven, causes them to flip back and forth through this polarity very, very rapidly, which then leads to that very rapid and sharp microbubble burst that maybe some of you all have seen, but also that type of rapid heat transfer, which is critical to obtaining that type of active ablation in a rapid period of time. Now, there are multiple types of systems out there. I am not going to walk you through which ones are better or worse, because it depends on you. It depends on the size that you're going to ablate, the maximum size you're going to ablate. It's going to depend on the parenchyma that you may use. And it also depends on your needle targeting skill set. If you're an advanced ultrasonographer and you have no problem placing 3 lesions in order to ablate a 5 centimeter hepatocellular carcinoma, then a multi-probe system could work very well. There are other systems that have similar types of wattage that are a single probe system. Some are water cooled and some are not. Some are even CO2 cooled for that. Those are more minor inconsistencies, but potentially could play a role around your nursing and how labor intensive it is for your nurses to set the machine up. I have probably not seen a more powerful factor that will actually shut down an ablation program is if the generator is so complex that it takes away from the nurses doing what they need to do in the operating room and can create a great deal of discourse when you're trying to do these cases. So thinking about the workload that requires while you're scrubbed that is necessary for starting a generator is of utmost importance to make sure that a team-based approach is easier for everyone in the room for what you're trying to achieve. I don't want to put you to sleep about talking about electrical engineering, but understanding the type of microwave ablation probe that you are purchasing is critical. If you don't remember anything from this slide, the only thing I would remember is identify where the sweet spot is on the probe that you are using. And this video demonstrates that. The sweet spot for this probe is actually right in the middle of the needle. That is not always the case. There are some probes where that sweet spot is here at the end, and there are others that are closer to the shaft here. That's critically important to make sure that you're obviously placing the sweet spot in the middle of the tumor, but you also need to be aware that if the sweet spot is down here, you may have to extend the needle beyond the target tumor and need to make sure that obviously no collateral damage has occurred so that you can place the sweet spot in that middle. Understanding active heating and passive heating. Active heating occurs in that immediate almost 2 to 2.5 minutes as those water molecules are being flipped back and forth. Passive heating occurs with longer duration of microwave out to 6 months and is based on that type of passive energy transfer outside of the active treating zone. Understanding from your instructions for use as to how much you get in an active heating zone in a short time versus how much you're relying on a passive heating zone is critical. And why it is critical is also based on the water content of the liver parenchyma that you are ablating. A more fibrotic tumor and a more fibrotic liver parenchyma will have less water. Less water means less passive heating to generate that type of ablation defect. Also understanding just from the IFUs, these are publicly available instructions for use for a number of different types of ablation systems. I only bring this out there so that you understand there is some variability with microwave, to understand that. And there is some variability. There is some variability in regards to the radial diameter of the ablation that can be achieved over the amount of time that it takes to achieve that. If time is something that you are not as focused on, then most of these are pretty much equivalent. If you want a more efficient type of ablation, 6 minutes or less, which is sort of, people say, sort of the critical time point, then there could be other ablation generators that may be better suited to you for what your practice demands and is interested in. The other is obviously the wattage that is available and the type of ablation that can be achieved. The Solero system outlined here is a high-powered 140 watts, 6 minutes, which can give you that type of ablation. The Amica system gives you a slightly similar ablation using less power, and that's related to the efficiency of how much power is being generated at the probe tip. You do lose some with the Solero system, which is why a difference in power gives you a very similar ablation volume at a similar time. Imprint, again, slightly different type of efficiency, but again, can treat these types of tumors. Single probe new wave system at a lower wattage will give you a slightly smaller and a more oblong like of ablation if you're treating a larger tumor. Aware of that is critical because the new wave system does allow you to place 2 to 3 probes simultaneously to potentially get that type of additional ablation volume if you need it. That's obviously critical to understand what happens at 6 minutes. At 10 minutes, you get obviously slightly larger ablations, not significantly larger with some of the devices, but obviously the ability to treat a 3-centimeter tumor far more definitively, both with the Imprint system at 100 watts and what you see with a single probe new wave or a single probe smaller type of probe design, demonstrating again what size of ablation are you potentially going to focus on, and that target tissue will allow you to dictate which potentially device and probe would be best suited for your practice. Now, the optimal microwave technique is critically important on ultrasound. I can tell you there is no microwave ablation system that can overcome bad ultrasound imaging. You must know the quality of your ultrasound before you embark on this. It is critical for the optimal trajectory of your needle and to make sure that you are placing it within the longest axis. Ultrasound technology will also allow you to overcome challenges in histology, especially for a cirrhotic liver or for a metastatic colorectal cancer that has significant amount of cache type changes. And the type of parenchyma is also of utmost importance. And then you deciding from the instructions for use, are you potentially going to be an active and passive ablator, meaning placing one needle, planning on doing it for 60 minutes, meaning trusting the active and then trusting the passive? Or are you potentially going to be an overlapping active, meaning doing multiple shorter ablations of 2 minutes and overlapping the ablations lesion in order to get an equivalent type of ablation volume? That's a decision you need to make. I have my biases, and I'm happy to walk you through that. One case example will demonstrate my biases and why I believe that type of aspect. And this is this case example. You can see roughly 4.5 centimeter intrahepatic cholangiocarcinoma, who actually had 4 or 5 lung mets, was treated with upfront chemotherapy. The lung disease remained stable and actually went away, and this was the only persistent disease. We wanted obviously at least a 1 centimeter margin, a little bit less here just because of gallbladder fossa, but the goal was to attain that type of margin. I commonly will use a laparoscopic approach and do multiple overlapping ablations, starting in the deep part of the parenchyma so that I don't obviously obscure my imaging anteriorly or more superficially, and then pulling back and getting that type of active ablation. So 4 ablations of 2 minutes each is the critical piece that I do in order to attain that type of ablation volume. The optimal ablation technique in my bias, and just so I'll give you some of my opinions of this, is that I do believe that a laparoscopic ablation approach, when ablation alone is planned for, is optimal. It is optimal predominantly because of staging and the optimal staging, and it is optimal for ultimate targeting because you do have multiple access points to achieve that type of ablation. There is a caveat. Laparoscopic ablation is technically demanding. It does require you to have advanced laparoscopic skills, but those can be acquired. That is a trainable technique that once you establish where your skills are now, going through that type of stepwise approach and gaining experience can allow you to obtain that advanced laparoscopic imaging technique, as well as that advanced laparoscopic ultrasound skill set. Both of these are easily obtainable if you stick with it and move through that educational process. I do believe that, again, a laparoscopic ablation is equivalent, and there is data out there that shows it is equivalent to open ablation, and we are finding that that disease-free interval quality standard that I mentioned to you, 6 months or greater, is actually superior for laparoscopic ablation than it is for percutaneous ablation. And that is not because the technique is better, it is all about the optimal staging. Laparoscopic is able to identify those other smaller lesions that may not be able to be seen percutaneously. Again, that staging I do believe is superior to perc ablation. The invasiveness is essentially equivalent. Laparoscopic ablation can be performed easily with 3 probes and a maximum diameter of incision being 2.5 centimeters in total length. Optimal hospital stay, a median of 23 hours. That is far superior to open ablation. And I do believe it has an optimal multidisciplinary care. It is not uncommon that nearly 70% of the patients that I perform ablations on are on concurrent chemotherapy. And we are doing their concurrent consolidative ablation on their off week from systemic chemotherapy. And then ablation recurrence, as I mentioned before, is where laparoscopic ablation is superior. As I tell people, and you're embarking on it, make it easy. And what I mean by making it easy, start with a 12 millimeter probe here, either a Hassan technique or varies, however you do it, but you need that 12 millimeter probe for your ultrasound. We then use a 5 millimeter camera. And then the only thing else I recommend is either a disposable or non-disposable 2 millimeter port that you should place in line as high as you can, and you use that for the underlying directional torquing. I do not recommend that any needle or any ablation probe be placed purely percutaneously through the skin. One, small incidence of needle track seeding, but the other is around the torquing and placement of that needle. Having that type of port here allows you to take all of the radial force off of the needle and allows for far easier placement and tracking of the needle when you're using the ultrasound. Choosing an ultrasound ablation device that potentially even allows you to place the needle through the biopsy guide can actually make laparoscopic ablation much easier. And then laparoscopic ablation also allows you to have that manipulation, so you can lift the lesion away from vital structures to make sure that collateral heat damage doesn't occur either to the duodenum, potentially to the gallbladder, stomach, as well as obviously vital portal inflow when you're treating more base type of lesions. So in summary, I know I've beaten the horse about patient selection, but I do believe it is critical to the success. Understanding the tumor size that you want to start with, understanding the tumor location, and depending on where you live, the body habitus. I'm here in the Mid-Atlantic or south in Louisville, Kentucky, and our BMI rates for patients who present with hepatocellular carcinoma and ablations is an average of 37. So it is a harder type of ablation than, say, for BMI of 25 or less. Know your ultrasound technology. If you don't know anything, make sure that it has a high definition image. Continuous ultrasound during ablation is required. It will truly allow you to confirm your targeting is optimal if you use that. Open needle placement is obviously easier than hand-assisted than lap. Hand-assisted is not a demerit. If you want to convert from an open ablation technique to pure lap, utilizing a hand-assisted technique is more than acceptable. And it sometimes can help you maintain that minimally invasive approach, which is clearly a benefit for the patient during their hospital stay. Thus, in conclusion, I truly believe after achieving these critical steps, you will have the best ablative experience and, more importantly, the utilization of that. Is there a best ablative device? As I said before, it all depends. It depends on you and your practice and your referral pattern and your multidisciplinary team. I do believe if you are asked to start with one ablation device, I would recommend a microwave ablation generator and needles because it gives you the greatest flexibility with a reasonable cost to grow your HPV program. Getting more advanced ablative generators and devices can come in time, but I think starting with that foundational piece will help you the most.